Everybody can see my screen? So great. Good afternoon, everybody. And I don't have any disclosures to make or conflicts to my knowledge. And so let's start with the learning objectives and what I hope that you'll get out of the talk today. So the goal is for me to impart you with a framework for understanding grief and bereavement. And I'm hoping by the end you'll have some knowledge in terms of how this can be used in your own clinical practice. And so, oh, this is my poll. Don't look at it yet. Okay. Please launch the poll. Do I need to do anything like stop sharing?
No, sorry, Sage,
Okay.
if you could launch the poll.
So just some brief questions just to get into the topic. That's not my question though. It's a good
Good
question.
question.
Okay, interesting. The word loneliness will come up, as will DSM-5 very briefly, but that's not my poll question. So how about disband with the poll, and unless you can do it quickly, because that's not a poll. And it was more just for your own reflection. So how about we stop the poll? And good thing that I have the slide with the poll. Oh, do I have to close it or you can close it? Okay, there we go. It was just open on my screen. So, all right. So the first question was it true or false? Was that grief normally proceeds through stages? I was really interested in whether you'd say that was true or false. And then another question was having had a close relationship with the person that's died is protective in bereavement. And finally, grief has a time frame, although recognizing that it can vary by culture. So we'll revisit that. I want to just begin with some definitions first. And so bereavement is the actual experiencing of the death of somebody close and somebody with whom you had a meaningful relationship. And grief is the actual response. And I can't look at it now, but please type in, well, I was going to ask if there's other things because that come to mind for you, because grief is universal, but it's expressed differently. And these are some of the common things that people will list as the response to grief. And I want to just also make clear that I'm a geriatric psychiatrist and grief is a normal human experience. So why am I here talking to you? An analogy from Columbia's, it's the Center for Prolonged Grief. If you fall off a ladder, most people will be bruised. Some people will break their ankle. That is still a normal and understandable response, but sometimes people need a little help. So typically the initial response to grief is very intense and as any significant loss can be, and overwhelming. And unlike depression, though, you may hear them, laughing through their tears as they have positive recollections of the person that's died. But especially early in grief, people are often preoccupied with thoughts about the person that's died. And to cope, they may, blame themselves or try to undo it or protest it. And they may think about their own death and joining the person. And bereavement itself is a risk factor for depression, but it's not the same thing. And Kathy Shear, who is the person that started the Columbia Center for Prolonged Grief, she talks about grief as at the first and foremost, it's a stress response, but it's also about separation. That's where the yearning comes from. And we'll talk more about that later. But the challenge is to adapt to this kind of new universe that you might find yourself in without your loved one. And she says, grief is the form love takes after someone dies. So acute grief is intense and it is painful, but it changes over time. And it's a process of integrating and adapting and reconfiguring your relationship with the person that's died. But the grief can be evoked like waves through anniversary reactions, celebrations, and often very personal triggers. So the key question is, how does this happen? How does acute grief become permanent? And if grief is a normal human experience, I want to emphasize why this is relevant and the rationale for talking about this topic today. But also, let's spend a few moments on other kinds of losses. So Ms. G is somebody that I followed who first came to see me, not because of the death of her daughter, but about 6 months after that, her husband was hospitalized. He was quite ill, and she'd actually had quite a lot of resilience. And that's not the story here as well. But the point is that just last week she was quite sad because her son-in-law was remarrying, not because of that, but because this time was one where she wanted to speak to her late daughter, who she was extremely close with, and they would chat about everything. And that's what the sadness was about. And Ms. W is another person that I followed who doesn't live in a big city, and her husband developed macular degeneration, so he can't drive. So they can't go antiquing and they can't go to their grandchildren's hockey games out of the area. And her friend recently moved to a retirement home. So she's depressed. And the snowball image is just that you can say cascade of loss or synergy of loss, but losses can be very impactful when a family member is ill, if there are cognitive changes, losses of mobility, loss of a license can be a profound trigger, as can retirement and forced moves. And a lot can be formulated as a loss. And then there's the term that Pauline Boss has come up with called ambiguous loss, which perhaps you're familiar with. So an example of somebody that's physically present and psychologically absent, the loss of somebody with Alzheimer's, a partner with Alzheimer's, or the second would be somebody that's been kidnapped. And we can also talk about disenfranchised grief, which is this notion of grief that is minimized or overlooked by society. So again, loss of a pet, miscarriage is a classic example. Having to give up your possessions. And I'll just very briefly, anticipatory grief. So a systematic review actually shows that people that had more grief distress before the death actually had worse outcomes. So these are not simple or straightforward concepts, and that's really what I wanted to share. And it's always important to think about who's going to be vulnerable in the aftermath of a loss. And so bereavement, feeling that the death was preventable, sudden loss, suicide, murder, but also watching your loved ones suffer. Personal factors can make a difference. Other stressors, other illnesses, and also certainly factors like your social support network and equity factors as well. And isolation and loneliness. And relationship with the deceased is another factor. So the first one, conflict, ambivalent relationship. Second one, we were soulmates. Who's going to be more vulnerable? If you go by the psychoanalytic literature, you might say the first one, but actually the second is quite a significant risk factor, as has been borne out in many studies. Oh, I didn't remember that I animated that. There you go. Okay, so now we're going to talk about going from A to B or P, because we're talking about how acute grief becomes permanent. So really it's a question of what is the process of grief? We've talked about other kinds of losses, so let me spend a moment on why this is relevant. So when I talk about the impact of bereavement, as a psychiatrist, as a physician, I want to talk about bereavement-related depression and prolonged grief disorder, and also health outcomes. So we'll begin there, because bereavement can have quite an impact on health. And so mortality in widowhood, many studies, big studies, first 3 months of widowhood in particular, but the death is by all causes. And yet, you've probably heard of the broken heart syndrome, first described by Parks in 1969. And in the Globe, he may have seen that it was just this week, actually, a commentary and opinion on it. And so what we do know is that there's increased mortality because of cardiac changes. And this was a large study, too, that looked at bereaved spouses and increased risk of death and other factors that can account for these outcomes, certainly. And another interesting phenomenon is Takotsubo cardiomyopathy, first named in Japan, a stress cardiomyopathy that causes dilation of the ventricle, and it can cause shortness of breath and can be triggered by public speaking. I find that interesting, but it needs treatment. But basically, the bereavement literature, and there's many more references, increased infections and immune response is blunted, increased cancer rates, greater use of benzodiazepines and healthcare visits, cognitive impairment, slowing of processing, and also unmasking of cognitive issues is something interesting when the spouse that's died is the one that was covering up. And then we see that people are actually have some significant issues that were missed by the family. And also want to just mention suicidal thoughts, even in the absence of depression, has been recognized in widowhood, at least. It triggers problem drinking, more smoking, panic disorder, increased rates in the aftermath, generalized anxiety, phobias, and PTSD, which is often comorbid, but can occur as an outcome as well. And then other factors, and as I'm mentioning these, just think about how these can intersect and magnify the loss of a spouse, for example, but then it'll also play into how you access supports in the aftermath. And I don't know if I went through that too quickly, but the bottom line is it affects you from all spheres. So we'll revisit some of that. So in terms of bereavement-related depression, let's talk about that. Oh, sorry, I did help. I thought I would try to make a nice segue, but I guess in a 20-minute talk, it's not necessary. Okay, so bereavement and depression, or depression and bereavement. Key point is that you don't have to wait. If you're depressed, you're depressed. It doesn't mean that you jump in and guns blaring and stick them on medication, but always recognize that there's depression in the aftermath of a loss. And it's the same. The fact that it's understandable is not sufficient, because you know from other talks here as well that depression left untreated leads to worsening of depression and negative health outcomes. And under recognition is a documented problem of depression, and it reduces quality of life and increases suffering as well. And again, just to reiterate that a bereavement-related depression is major depression. Now, what's different is that there's also the grief component, but we'll talk about that. But depression is depression is depression. And it is prevalent. So many studies, older studies, these were just a few examples with a more recent study thrown in, that a quarter of people in the early months of loss might be depressed in the moment. And it continues, and particularly early in the loss as well. And I also want to talk about insomnia, because this is very much documented in bereavement. And with a loss of restorative sleep, you feel awful. It's hard to get out and do things, to re-engage. And insomnia itself has a lot of negative health outcomes as well. So it's all, again, a cascade or a synergy of loss. And again, my question now is, how do you get from A to B? Because it's often like this in bereavement. And now I'm going to talk a little bit about maybe what people call grief work, but what's the process that has to happen? And just to say that this is not a concept that has been borne out in the literature. So people in the bereavement world do not talk about the stages of grief, which you are probably all familiar with. Attachment theory, though, can explain a lot about how as human beings, we resist separation from our loved ones, and we look for proximity to the figures we've attached to. And what happens when somebody's passed on is that you yearn to see them and to touch them as a physical being, but you have to reconfigure those relationships so the person is internalized. And nowadays, it's felt that it's not about letting go of the deceased, but the fact that there's a continuing bond. It's just that it gets kind of reconfigured, and it's a different kind of relationship. And people that have that ongoing connection seem to have better outcomes, or at least less symptoms of depression. And finally, I just want to talk about this model. which is the fact that it speaks to the oscillations of grief, really. How you have the loss-oriented challenge where you're preoccupied with the deceased and there's intense pain, but then you also have to start turning towards adapting to life, being engaged with new relationships, new identities, new roles and routines. And you oscillate back and forth. So it's really not a linear progression, which is the point I want to make. And then, so we're going to meet Ms. Bereave. She can't stop thinking about her husband, and it's been 13 months since he's died, but it feels like it's yesterday, and she feels numb. And she can't look at his picture. Unlike the person that has pictures all over the house, she can't look at his picture, and she feels that nobody understands, and she's angry at the doctor because the doctor missed something, she feels. That's Ms. Bereave, and she kind of epitomizes something that we call prolonged grief, formerly known as complicated grief and formerly known as traumatic grief. So it is the same kind of grief. It's not a different entity, but it's the fact that acute grief just does not become permanent. So it's often comorbid with depression and PTSD, but not necessarily. And it has a lot of negative health outcomes, and it's prevalent. And this is a more recent study where the rates were higher in the context of COVID-19, but these were not older adults. And I'm going to be very brief on this slide because this is ICD-11, the World Health Organization, and their notion of prolonged grief is pretty much harmonized with DSM-5 TRs, but it's the duration is about 6 months since the death or longer. So prolonged grief, really the essence, it's kind of PTSD-ish in some ways, but it's more of the yearning and longing, and you're not afraid, but it's not PTSD definitely, and it's not depression. And so the intense yearning and longing, preoccupation with memories or thoughts, and at least 3 out of 8 symptoms that I will now share with you. And that would be a sense that a feeling like a part of you has died, disbelief, avoidance of reminders, intense pain, anger, bitterness, sorrow, hard to get back into life, you feel stuck, numbness, emptiness, life is meaningless, loneliness. And I wonder, just reflect if that sounds like anybody that you've encountered. These are not the people that are burning down the door to come for treatment because of the avoidance component. It's often very painful. And the treatment is really to facilitate this notion of accepting the loss. So the loss-oriented coping and the restoration-oriented coping to restore well-being. So that's why the process kind of feeds in and what it's about. And there's evidence from RCTs, and citalopram helps with depression, but not with the grief part. And it's in the limited time, I'm just going to give you the essence of some of the milestones here of a lot of it is about education, about what happens, and about establishing new connections, telling the story of the death with imaginal conversations. And you can go to the website, and you can also check out some webinars. And in my assessment, I don't use these, but TRIG is used in research, looking at intensity of grief, some other questionnaires that you can get off the website. But nowadays, we're going to be seeing a lot more of the PGD-13. And again, with the ICD-11, I don't know, this might be too much information, but I find it interesting. So, but what I want to do now is really focus on assessment. So bringing everything that I've just said into the clinical realm. And what's really important with somebody that's grieving is that you listen to their story. And I have spent a whole session hearing a story and not going through the whole, checklist of what I need to ask about, because it's so important that they can tell their story and feel listened to and heard. And relationship with the deceased is always something I'm always thinking of, who's going to be vulnerable. So who died? What did the relationship mean to them? How did they die? If they were a caregiver as well, caregivers are notorious for neglecting their own health, and that includes mental and physical health. So that's going to make them potentially more vulnerable. Was the loss unexpected? And keep in mind, even if you have a spouse that dies of a terminal illness, they could still perceive this as a sudden and unexpected loss. Losses lead to more losses, right? So there can be situations with the estate, lack of access to grandchildren when a child dies. And I always ask about anger and guilt, and whether somebody avoids reminders. So when they say, again, through their tears, that they have pictures of their husband all over the house, that is always a good sign, usually always a good sign. I want to, of course, know about personal vulnerability and other factors. Insecure attachments, that's something that makes people vulnerable to prolonged grief if they have a tendency to be avoidant in their coping. And again, low socioeconomic status, low social support, and ill health, chronic illness too, they'll be vulnerable. So the approach to bereavement-related depression is I would say straightforward, but the first thing to do is to treat the depression component, however you do that, because it's very hard to motivate people to make new connections and start new things and take on new identities when they're depressed. So again, it could be, social connections and exercise. It doesn't have to be a course of antidepressants, but just to spend a moment on meaning making. So what I mean by that is there are sources of meaning that help with processing any loss, and that's a sense of community, social support, of course. I've had patients that, search out a medium to talk to their loved one, and even if they don't believe, it can be very helpful. And some people are very curious about what happens to their loved one after death. Rituals, very important, new ones, old ones, religious, cultural ones, but also that can be a source of support, but can also lead to what's called complicated spiritual grief. And widows that believe they won't be reunited had more depression in one study, which was interesting. So it's a whole area, but it's distilled to 1 or 2 points here. The post-traumatic growth, though, is this notion that out of the worst situations, there are changes that can be positive, people that you meet in your journey. And it's very helpful to point that out to people over time, maybe not right at the outset. Establishing routines is very important, and there's evidence to support that in terms of sleep hygiene and exercise as a way to kind of minimize depressive symptoms and to prevent their emergence. So these are always important, but there are studies specifically related to bereavement that really support the health promotion. And just to wrap up, or nearing the wrapping up portion, the part of the approach is to recognize who's vulnerable. And bereavement can result in depression, prolonged grief, and adverse health outcomes. I also just want to say that older adults as a whole are quite resilient. And I've actually seen people that are feeling guilty because they're doing so well, and that is normal. That is normal. I don't want to use normal or abnormal. That is healthy. People do not always have profound distress. Those are not the people I worry about. The people that I'm doing okay, I'm sad, but it's going to be okay. Those are people that, in fact, tend to be okay. As somebody that does this work, again, it's not what you say, but how you listen. And it's really important to not be judgmental. And one of the dangers about this work is that if you're treating somebody, well, as a psychiatrist with schizophrenia, I'm not going by my personal experience of how I think that person should be doing. But virtually everybody has experienced a significant loss, and we tend to apply our own circumstances of how we did with bereavement, even though there's like a very vast bereavement literature. This notion of permission to grieve is really, really important too, that, that people feel whether they're angry, distressed, giving them permission to feel however they are feeling. And this is something that's been very helpful too, just this concept that, that you have the loss and it's everything, you're preoccupied with it, but the more you do, the more you connect, it kind of shrinks, because it's like the salt in the glass of water versus the salt in the swimming pool notion. And then, anniversary reactions. People can feel like their grief is kind of evolving, and then they feel like they're hit by a wave, and it's because they don't recognize the anniversary reaction, which just isn't just your wedding anniversary or the anniversary of the death. It could be the weather when somebody had their diagnosis. So The importance of rituals, that includes creating new rituals. So people that, it's Christmas and they can't bear it. So, but the person loved food. So every Christmas now you make a new soup, or you volunteer to give out turkeys or something that commemorates. For many people, journaling is important, including journaling to the person that's died, journaling angry feelings you have towards the person that's died, imaginal conversations, and then also resources like from poetry, literature, and what I've done is I've included a bunch of things that people have found. I found the poetry one very useful, or interesting anyway. And there's a number of books and poems and things that are highly touted. And then I wanted to get back to the poll question, my second to last slide. So the idea that normally grief proceeds through stages is not current thinking. It's oscillations. There may be some value in the kind of the concept, but people shouldn't feel like they have to adhere to that. And having had a close relationship with the deceased is not protective. You can have a lousy outcome if you had an angry and conflictual relationship, but people that had close, very intertwined relationships are often quite vulnerable, and they have increased risks of both depression and prolonged grief. Grief has a time frame? No, grief is timeless, but it changes. It evolves to be permanent and integrated. And there is cross-cultural variation, but this notion seems to be bearing up across cultures. And then, so that's the formal end, but if you want to continue the dialogue about bereavement, the GPOC, our course is going to be launching February 23rd, but this year you can do it by choosing a module on key topics in geriatric mental health. And the bereavement module that I happen to be doing is starting on March the 1st. But what's different from ECHO and this is, it's really about, it's kind of like having a study group where you go over a case and short answers. And we're pleased to have some international participants so you can learn about things from different contexts. And if you want to hear more, check it out. It's not free though. And I think I will end there.